Assalamu alaikum. The clinical day. We have Mr. John, 21 years, present with weakness. The vitals are normal. You can start now, please, Dr. Azhar and Dr. Roda.
Yes, start.
Yes,
Yeah. Hello there. I'm Dr. Zain, one of the doctor covering the service today. Am I talking to Mr. John, 21-year-old?
yes,
Yeah. Nice to meet you. We are here to discuss issues related to your health. After that, I will examine you and address your concern, all right?
all right.
All right. So tell me what the problem.
Doctor, I have a weakness from the last 6 months.
Mm. I'm really sorry for that. So what do you mean exactly by weakness?
That I'm feeling very weak. I'm feeling very weak.
Mm.
Especially, I'm having weakness in my legs.
Mm, all right. So, have you got these issues before?
No, first time
Mhm.
I'm having
Yeah. And is this weakness only on your legs or all over your body?
only in my legs.
In your legs. All right. Is it started all of the? I understand that for 6 months started gradually.
Yes, started gradually.
Is it keeping progressing?
Yes, yes, it is progressive. From the last 6 months, I was feeling weakness in my legs, and from the
Mhm.
last 3 months, I am having my balance. I cannot maintain my balance.
All right. All right. So you cannot control your balance. All right. And is it painful?
No,
And does it like increase with any specific time of the day, like at the end of the day?
no, it is present all the time.
And is there anything make it worse?
No, I did not notice anything.
Anything make it better?
Nothing.
Really so, and I'm afraid that it affect your daily life and job.
Yes, yes, it is. Thing.
I'm really sorry for that. Then you said there is an issues with your balance. Is it like mainly when you like in the dark area or all over the time?
It is all over the time.
Like, do you
Especially,
swing to one
especially,
way?
especially in the dark area, I'm having more.
More balance issue.
Yes.
All right. Do you have any fits at all?
Huh?
Any fits?
Fits? No.
Any pins and needles?
Yes, yes, I'm feeling pins and needle numbness in my legs.
And what about your hands?
Hands are normal.
All right. All right. Do you have any back pain or a back trauma?
No,
No. All right. Do you have any memory issue?
no,
Any sleeping problems? Any sleeping issue?
no,
Any problem controlling your bowel motion or your water work?
no.
What about your mood?
Mood is normal.
Mood is normal. All right. Then I would like to ask you, do you have any past medical history that I should be aware of
I'm having diabetes from the last 5 years.
for the last 5 years? Is it controlled?
Yes, it is well controlled.
Well controlled. When the last what the last number of your accumulated blood sugar? How much?
Once last month I have it, and the doctor told me it was 7.5.
And are you following up with the eye clinic, food clinic, kidney clinic, all of them?
Sometimes I'm going there, sometimes I'm not regularly.
All right. And what kind of medication for diabetes are you on?
I'm taking insulin and
All right.
metformin 500 milligram BD, and insulin
Uh,
I'm taking mixed art. I'm taking 70 over 30. I'm taking two
all right.
times.
So insulin and metformin,
Yes,
are you compliant with them?
yes, yes. I'm trying, but sometimes I'm missing, but mostly I'm trying to take it on time.
All right. Any change in the doses recently?
No.
All right, all right. And do you have any like a problem with your cholesterol?
No.
Any heart issue?
No.
Any surgery?
No.
Any admission?
No.
All right. Do you have any headache?
No.
Any vision problem?
No.
Uh-huh. All right. Then I would like to ask you further. Do you have any change in your weight?
My weight is normal.
Good. Any lump or bump?
No.
Temperature changes?
No. No. No fever.
Oh, okay. Weather preference?
No.
All right. Are you on any specific kind of a diet, like eating special diet?
Yes, I'm mostly taking vegetarian diet.
And for how long?
From the last 2 years, I'm taking.
You are telling me. All right. Then I would like to ask you further. Do you have a family history of similar condition?
No.
All right. All right. Do you have any heart pain?
Any?
Any heart pain, like a chest pain, I mean?
No. 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 No.
Any heart racing?
No. No.
Any shortness of breath?
No.
All right. Any cough
No.
or a noisy breathing?
No.
All right. What about your bowel motion?
It is normal.
Tummy pain?
No.
Any pallor?
Yes. 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 Everybody is commenting that I'm getting paler and paler day by day.
I understand that. Do you have any yellow discoloration of your eye?
No.
All right. Do you have any joint pain
No.
or a rash?
No.
All right. Do you have any frothy water work?
No.
All right. Any change in your water work at all?
No.
No. Hello?
No. 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 No.
No. All right. Then I would like to examine you. During examine you, I may ask you further question. All right, Mr. John.
Okay.
All right. Regarding the surrounding, any like a wheelchair, any stick, something.
Yes, I'm still now I'm sometimes I'm using sticks sometimes, but mostly I'm using nothing sometimes.
All right. Then I would like to. Can he walk?
Yes, but now if I try to walk, I cannot maintain my balance.
So I will do the Romberg test.
Yes, Romac test is negative.
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 All right. Then I will inspect for the lower limb for any wasting,
No, no wasting.
fasciculation,
No,
abnormal posture or scars.
no.
All right. Then after that, I will check his tone, the lower limb,
Yes, tone is raised.
raised. All right.
Yes,
All right. Distal, proximal, or all over.
no, all over.
Power.
Power is reduced bilaterally.
And what about the reflexes?
Reflex is upgoing.
Reflexes upgoing and or including the plantar and clonus.
Yeah, just plantar bardo upgoing.
All right. And the power is reduced.
Yes, power.
All right. What about the sensation for the posterior column, the vibration and position sense?
They are reduced.
Up to where?
Up to the knee.
Up to the knee. What about the pinprick and fine touch?
They are also reduced.
Both the reduced. What about the coordination?
Normal.
All right. Then after that, I will offer eye exam and I will offer fundoscopy. Any abnormality apart from the pallor?
Nothing.
Nothing. I will also check the abdomen for any organomegaly.
No, nothing.
Nothing. And yes. Then after that, I will check the hand for any pallor, leukoplakia.
Yes, pallor is there.
All right. Any tanning, any abnormality, any joint deformity, no.
No, no.
Yeah, and the pulse is regular, and we'll check the neck for the lymph nodes,
No lymph nodes.
and I will give water to sip for any thyroid swelling.
No.
All right, and no raised JVB. All right. Then I would like to ask you, what do you do for a living, Mr. John?
I am a teacher.
I'm a teacher. We will inform the occupational health worker for this regard about your condition. I try and solve it. All right. And
Okay.
all right. Do you smoke?
Yes.
How much?
10 cigarettes
Or over how long?
for 5 years.
Actually, smoking is hazardous for people health. I'm advising you to stop it. Do you think you can do it?
Okay.
Do you drink alcohol?
Yes, I'm drinking alcohol.
How much
30
in a
units
week?
per week. 30
How much?
units per
30?
30. 30.
30 units in a week. In a week, actually,
Yes.
it is above the recommended amount per week. Plus, it could be also hazardous for you in your condition, especially. I'm advising it to reduce it, if not stopping it. And for that, we will refer you to the specialized clinic. All right.
Okay.
All right. Do you have any binge drinking?
No.
All right. Do you have any neck pain at all?
Neck pain? No.
No. All right, all right. Sorry for jumping. And then, do you wake up at the morning that looking for alcohol?
No, no, no.
All right. Anyone annoying you for drinking alcohol?
No, no.
Do you feel guilt with drinking alcohol?
Sometimes.
Sometimes. All right, all right. Then with whom do you live?
I'm living with my wife.
With your wife. All right. Do you have kids?
Yes, I have two kids.
Do you have issues with your, I'm going to ask you a sensitive question, sorry. Do you have any issues with your intimate relationship?
No.
No, all right. Any casual?
No, no casual relationship.
Are you, sorry for asking you this also, are you on any illicit drug?
No, no, I'm not using.
Oh, all right, all right. So just to sum up for you, Mr. John, that you have this weakness started gradually and getting progressing for the last 6 months, and also you have issues with your balance. So you denied any eye problem.
2 minutes
And
left.
all right, and
Yes.
yeah, and you are pale and you are a vegetarian. Do you want to add for me anything?
Yes, if sometimes I do exertion, I have the shortness of breath, and I also feel dizzy on exertion.
And do you have like this short breath more when you lie down or all the time?
No, no, only when I do exertion.
I'm really sorry for that. So what's your concern?
What do you have? Why I'm having this problem?
Actually, I appreciate your concern. I think this weakness, we called it due to deficiency of a vitamin. We call it vitamin B12. This could be related because you are a vegan, that you all only like eat a plant, and this kind of a vitamin find in animal product. This deficiency leading to the symptoms that you have of being pale, and when you exert yourself, you have shortness of breath, and most importantly, related directly to your weakness. Also, this weakness could be like also exacerbated by your drinking much alcohol, and yeah, and for this, we are gonna like admit you for a while, run blood test, including your blood level, doing investigation, and imaging. We will including the blood doctor and the nerve doctor and a specialized nurse for this regard. And if your blood level runs to be like very low, we may give you a blood. And we will see what the nerve doctor will see, and we will include the dietitian and physiotherapist for your condition. All right, and also we will refer you to alcohol cessation clinic to see about this. Do you have any other questions?
Yes, it is curable.
Actually, it depends on the stage that you are on. And the level of the damage that could happen to the nerve due to this deficient vitamin. And we will update you about this, all right?
Okay.
Okay.
Time is up. Examiner questions.
Yes, please present your case.
This 21-year-old male presented with a progressive weakness, mainly in his lower limb for the last 6 months, associated with losing balance, especially when the like in a dark area, and also with the pins and needles. He also gave a history of being pale, associated with a shortness of breath and being dizzy. He is a vegan. He denied a family history of similar condition on examination. He has a mixed upper and lower motor neuron sign with a negative coordination. All right, putting all of these together, I will put the mixed upper and lower motor neuron sign first for the vitamin B12 deficiency for the severe combined degeneration of the cord. Yes, this is my sum up for the case.
Okay, then what will be the differentials?
Apart from the severe combined degeneration of the cord due to vitamin B12, I can put also I can put also hold on. It can be syphilis, but he denied casual, although I should ask about other risk factors. And he denied any pain in his leg and any vision issue. It could be also motor neuron disease, but again, is that he has sensory symptoms. It could be also Friedrich, like ataxia, but he denied a family history of similar condition and no cerebellar sign. It could be also any vitamin levels like copper, zinc could give a similar symptoms to vitamin B12 deficiency. And it could be, and also the alcohol may play a role in his condition.
Any other differential?
Differential for the combined. Hold on. It could be a motor neuron disease. Yes, I see this. It
Maybe
could
diabetes. Maybe diabetes.
Yeah, maybe the diabetes. Yes, exactly. Diabetes, but it could give it would give like a lower motor neuron sign mainly, but it may play also a role in his condition. Yes, you are right.
Then any other differential like
Other differential.
MS maybe? The MS, you can think over MS or not?
Actually, yeah, all of them are he have hypertonia and hyperreflexia. Am I right?
Yes. And no lower motor neuron sign. I did not say any lower motor neuron sign.
Yeah, exactly. Sorry for mixing up. Sorry, really. So he has upper motor neuron sign. Yes, it could be motor neuron disease. It could be MS. It could be also vitamin B12 deficiency. It could be like a tumor in his spinal cord or any like a disc prolapse.
Okay.
Yes.
Okay.
Yeah, you are right.
Enough. How you will investigate?
Apart from the basic lab, I will do like a full blood count and checking his hemoglobin and doing a film, blood film for microcytosis. I will do also inflammatory marker. Also, I will do EMG and nerve conduction study. Also, I will do MRI for his spine. Yeah, and also I will include MRI for his brain. Yes.
Then any other investigation
Other investigation for this
uh,
case
for vitamin B12?
or vitamin B12. The,
Do you
the,
want to
the
rule out,
yeah,
do you
the
want to
intrinsic
rule out
factor.
any other autoimmune condition?
Yeah, the pernicious anemia.
Yes. So what you
Yeah,
will do for pernicious
yeah. We'll do the intrinsic factors and autoantibodies, I think.
and
There is a
Schilling test?
screening test. Yes.
Test. Okay. Then any evoked potential will you do?
Evoked potential for the eye and ear. Yes, for the MS.
Visual and somatosensory. Then how you will manage it?
And a multidisciplinary team approach and educate him about his disease counseling, including dietitian, physiotherapist, occupational therapist, and occupational health worker, specialized labs, and like to stop alcohol, stop smoking, and see with the dietitian about this vegan and how to modulate this. And also, and then according to the cause.
Okay.
Yeah.
Okay. Thank you.
Mhm.
So you will give vitamin B12 at the oral or intravenous, no?
We'll give him like injection.
Injection or oral. It will depends upon the investigation. Okay. Thank you.
You're welcome.
Thank
Okay, well done, Dr. Roda, and thank you for the case, Dr. Azhar. Last question for Dr. Roda. If there is coexisting folic acid deficiency,
Hmm.
which vitamin you will correct first? If you have
Uh,
folic acid and vitamin B12 deficiency, and you suspect subacute combined degeneration.
I think I will correct. If I will correct vitamin B12 cells.
Perfect, yes. So remember the alphabetic B before F, right? B before F.
Yeah, you are right.
So yeah, so you're correct, vitamin B12 before the folate. Otherwise, you might exaggerate the weakness and more vitamin B deficiency if you started by folic acid. Because vitamin B12 is consumed in the metabolism of vitamin B for the folic acid, sorry. So you will cause more vitamin B12 deficiency if you start correction of folic acid. Okay?
you. Yes. Yes.
Yeah, okay. Dr. Azhar, your comment now?
I think mashallah she did very well. Only there are few points about this differentials, and she was telling that this is a mixed upper and lower motor neuron. I did not give any lower motor neuron sign on examination, and she only can say this is subacute combined degeneration complicated by symptomatic anemia. Patient is paler and dizziness on exertion, shortness breath on exertion, and few there is a uh, differentials. Uh, I gave some hint, and in the investigation, autoimmune pernicious anemia should be ruled out. Otherwise, she did very well.
Yeah, I agree with you, but I want to ask about Romberg test. You have now dorsal column affection. So suppose dorsal column affecting or lead to sensory ataxia, right?
Yes, yes, sensory ataxia.
So the Romberg test supposed to be positive, right?
Yes, I told it is positive more in the negative room.
I think you said negative. Anyway, it will be positive, right? When he stand, he will fall if he closes the eyes.
Yes, yes, yes. If I said maybe, sorry for that. If I
No
told
problem,
like
no problem. That's why I wrote it on the time when you mentioned no, it's negative. Supposed to be positive, yes.
yeah, yes, supposed to be
Yes,
positive.
you're right. Okay. Apart from this, yes, she did great. I think she covered and she catch the case when she asked about the diet, which is very smart
Yes,
question. Yeah,
yes,
very.
the diet.
Yes, the diet here will be the clue. If you didn't ask about the diet, you might lose the case. And by the way, any diet, any diabetic patient, you have to ask about the diet. But particularly in this patient, you have to extend the question to, are you strict to any diet? Because it might be vegetarian, as in this case, and it will be the case. If you didn't, you will miss the case because all diabetic neuropathy as peripheral neuropathy will be downgoing. I mean, lower motor neuron lesion. But in this patient, he has upper motor neuron features. So it will go more with spastic paraparesis as subacute combined degeneration.
Yes, yes, yes.
Yeah, I agree. A very nice case, Dr. Azhar. Thank you so much. And well done, Dr. Oda. I think you can take a good mark in this case.
Yes,
Yeah, regarding all skills, you did well. Uh, yes, I think also the examination you did. But why we put multiple sclerosis here as a differential? But we
yes, a
can,
differential, but we can say multiple sclerosis. There will be multiple attacks,
yes,
but the
exactly.
patient
And
will have
also
only one type.
phenomena, we have to specify if to the
Yes, yes.
examiner. Suppose the patient will have on and off symptoms related to the hot bath or exposure to heat. Yes, you're right. But as a
Only for the
differential,
spastic paralysis. Only for spastic paralysis,
yes, yes,
we can
yeah,
put it.
yes. Peripheral neuropathy against MS. But I think in this patient, he has peripheral neuropathy, or you said he has only dorsal column?
Dorsal column involved.
Dorsal column, no peripheral neuropathy.
Yes, yes.
Yeah. Uh, the important point, Dr. Roda, you were about to miss, but Dr. Azhar remind you the pallor and dizziness while standing from sitting. If you miss it in the history, you can ask it during the examination. For example, you didn't ask about anyone told you are paler than before. And do you feel dizzy while standing from sitting? This is related to the history taking. You miss that and you forget. But during examination, when you ask for blood pressure, always remember, shall I ask for postural hypotension or no? If you miss the history, you can ask it, please, can I offer examining blood pressure sitting and standing? By this way, you rule out autonomic neuropathy. Plus some other symptoms like impotence, you ask it, which very, very well. The also GI symptoms, changing of the bowel habit, or feeling full after the meal, or stroke, other complication of diabetes. I mean, you have to rule it out. Anyway, you did it all as in general. You can pass this station easily. Okay.
Yes.
Well done, Dr. Roda. Thank you. Okay. Some comments before moving. Please post your scenario, Dr. Roda.
And there is another thing that you are right, Dr. Basim. Anyone with anemia, we should ask from a blood loss. We should ask about shortness of breath, dizziness, palpitation, and something.
Yes, you're right.
Yes, and regarding the differential, yeah, they wrote yes, anything myelopathy, subacute core, trauma, infection, tumor. Yes, because here with a sensory patient.
Sensory dorsal column affection. Yes. So the main subacute and tabes dorsalis, and our case here, the vitamin subacute, sorry, subacute combined degeneration, tabes dorsalis, multiple sclerosis. This is the main disease or pathology of dorsal column. You have to put them in the differential.
Uh, the Frederick ataxia we can also put, but against this there is no cerebellar signs.
Yeah, there is no cerebellar. It's against that, no cerebellar sign, yes. But they are differential to each other, all of them.
Yes, yes, yes.
Okay. Yes, spastic paralysis. Dr. Ahmad Mansour, yeah, peripheral neuropathy against multiple sclerosis, yes. The differential, myelopathy, subacute combined degeneration, trauma, infectious tumor, stroke. But I guess stroke will not cause dorsal column.
Yes, yes.
Yeah, I wrote yes, spastic paraparesis. Maybe this is the differential, but
But
particularly
if
dorsal. There's, yeah, you're right.
posterior but infarct in the spinal cord, then it can.
If there is, again,
Posterior cord infarct. Sometimes the artery connecting to the
yeah,
posterior
yeah,
vertebral column.
yeah, it's a very rare case, but it might happen, yes. But remember, always the most common MS, subacute combined degeneration, and tabes dorsalis. These are the specific pathologies affecting the dorsal column. Okay.
Thank you.
Thank you, Dr. Sam. Dr. Sam. Dr. Zeruda posed the case, 70 years old male, complain of short of breath for 4 months. Mr. John Smith, our usual patient, okay?
And vitals are
Any change of the vitals, Dr. Oda? Saturation, particularly?
All right, hold on. We can say vitals are normal, apart from the respiratory rate upper limit 20.
Okay. I am writing now. Respiratory rate only upper normal. Okay, this is your case, Dr. Asar. If you're ready, let me know. Anyone has comment before moving to the next scenario?
If you can mention again the differential diagnosis in this case.
In this case, will be our case, subacute combined degeneration due to vitamin B12 deficiency. You can, I think also alcohol, we can say alcohol here is important.
alcohol and
But
diabetes.
it can be ataxia with negative Romberg, and it's cerebellar.
Yeah, mainly cerebellar, yes. But
Mhm.
in general, Dr. Aisha, or
Yes,
particular to the
vitamin
case?
deficiency in alcoholism, yes.
No,
All
no.
vitamin deficiency.
Yeah, I got your point now. But your question regarding to the case, dorsal column
Yes.
affection,
The other
so
differential.
we can say them, but against Tuebis dorsalis, no history of syphilis. For subacute, yes, this is our case. And multiple sclerosis, there is no on and off history of the symptoms.
Mhm. Yes, and please about the signs of anemia here in this case. It is related to be vegetarian also, or it is
Yes,
related to
vitamin
the
B12. I will ask you this question. What vitamin B12 lead to anemia? What kind of
anemia?
anemia? What kind? Tell me.
Macrocytic, yes. It will
Macro
lead to, yes,
or
no,
micro? Macro.
macrocytic, yes, macro.
Yes.
Macrocytic.
Yes. So what MCV you will find?
High MCV,
More than
more than 90.
More than 100.
100, yes, more than 100.
100? Oh,
Yes.
okay. So, other differential for this case?
Yes. Yeah,
What
you
other?
mean the anemia?
No, the case, if he ask about other differential, we will mention the tabes dorsalis and maybe alcohol related.
Yeah, we
Maybe
will
the
say
vitamin
dorsal
B12
column affection.
itself.
We will say this is dorsal column affection, and the differential for dorsal column are, and you can mention them.
Yes, like trauma, also an infection and
Okay, you can say
compression.
trauma.
Yes. Okay.
But the most common are what we mentioned. I will ask you what alcohol can lead to in anemia. What type of anemia with alcohol, Dr. Raish?
And
Because
alcohol.
because
Yes.
you opened this topic. Yeah, tell me.
Okay. It can be like deficiencies also, all vitamins, and because there is the malnutrition in alcoholism.
So, what specifically type of anemia with alcohol?
I think also it can be all type, I think.
Okay, but
Macrocytic.
what is specific? Yes,
Macrocytic.
Megaloblastic.
megaloblastic. Yes, exactly. It's not macro. It's
Megaloblastic.
megaloblast.
Okay.
So MCV how much?
How much?
110 and
Above
above. Above
110?
110.
Okay.
Yes. Above 110, Dr. Ahmed. Yes. Dr.
Mhm.
Ahmed, man, how are you?
How are you? I'm joining you recently and I'm listening and I'm happy for this. Yeah.
Most welcome, Doctor.
I
دكتور باسم ازيك؟
have question, Dr. Bas.
Yes, go ahead.
Can you, يعني, if there is diabetes peripheral neuropathy, what will be يعني, the features? Can you?
Peripheral neuropathy in a diabetic patient?
Yeah, if the case is peripheral neuropathy.
So the diabetic itself.
Yes, diabetic peripheral neuropathy, yes.
And the vitamin also, vitamin deficiency.
Okay, thank you very much.
Most welcome. Yes, Dr. Mahanna. Dr. Mahanna, how are you?
Yes, Dr. Bassam. How are you?
I'm fine, alhamdulillah.
I'm
Your
all right.
You are hematologist or interested with the anemias?
No, I'm ICU. So
Oh, okay.
actually, I don't know the difference between megaloblastic anemia and macrocytic anemia. So this is new.
The MCV number, only MCV numbers,
Mhm.
110 and 100 only, or from 100 to 110. This is for macrocytic. For megaloblastic, it will be 110 and above, and it happened with alcohol.
Okay, because what I know, alcohol can cause macrocytic, but I don't know the macrocytic can be classified to megaloblastic as well.
No, the megaloblastic can include the macrocytic because the number
Mm.
is higher.
The B12 is also causing
Me-
megaloblastic.
Megalo, B12.
B12.
I think folate and folate and vitamin B12 only can cause macro, but the alcohol will cause megaloblastic.
Only in the exam we simply can say MCV will be raised.
High, yes, high MCV, yes, exactly.
MCV will be high.
Yes.
So
Mhm.
I will share type of anemias in the group later on after this session, okay? Just
I
to
think
be
I think
yeah.
Google said vitamin B12 deficiency and folate deficiency can lead to megaloblastic anemia, and the difference is I think they mention
Alcohol.
megaloblastic because
Liver disease,
im-
Sorry.
impaired DNA synthesis in the bone marrow.
Okay.
So I don't know.
Yeah, they mention yes, macro. Megalo is type of macrocytic. I search it
Yes.
now.
Mhm.
There is a figure containing all types of the anemias. I will try to share it from BAS tests. Sorry, BAS medicine. I will share it. It's more
Okay.
clear about types. But what I remember, alcohol is specifically for megaloblastic.
Megaloblastic, it's in the bone marrow. They said in the bone marrow. It's not the size of the cell. It's megaloblastic. This immature red blood
Mhm.
cell precursors in the bone marrow. Um,
Yes, megaloblastic means that the neutrophils or the RBCs, sorry, have many nucleus.
Okay, let's make it the opposite because I mostly I mix. I Google alcohol is the one causing macrocytic, and folate and vitamin B12 they are the one causing megaloblastic. So sorry
Yeah,
guys, I
yes,
made it in the opposite.
that's
So
yes, yes.
yes, so I mix
Alcohol
I
causing
make I made the
macrocytic.
opposite. Yeah, so the vitamin B12 and folate they are important for the bone marrow and they can cause the megaloblastic. That's why
Megaloblastic.
also in pernicious anemia you might have megaloblastic because
yes.
of the vitamin deficiency. But alcohol will cause only macrocytic. Sorry for this error. I have to apologize. And I should admit. Okay, let's
Okay.
move. Thank you for correction, Dr. Ahmad Mahanna, and refreshing. Are you ready, Dr. Roda?
Yes, yes, yes.
Yes, let's go.
Just few seconds.
No problem.
Yes, let's start.
Yeah, here you go.
Okay. Hello.
Yes, hello.
I'm Dr. Azhar. Today, one of
Yes,
the doctor in the chest clinic. Are you Mr. John Smith, 74 years old?
exactly.
Okay, today we are here to discuss some health issues, and I will also examine you. Is that okay with you?
Please.
Okay. Please tell me what brought you here today?
Yes, I have this shortness of breath. It keeps increasing, doctor, and it really impacted my life.
It is for how many months?
Say for the last 3 or 4 months.
And how it started suddenly or gradually?
Don't remember.
Okay. It is present all the times, or sometimes it is there, or sometimes it
All
is
the
not there.
time.
Have you noticed anything that increased this your shortness breath?
Actually, doctor, now I cannot even fly the flight of a stair, doctor.
You can. Okay. This shortness breath, have you noticed anything which makes it better?
Not at all.
Not at all. Okay. At night, you are you taking more pillows?
Mm, no, I sleep on one pillow and I'm doing this before.
Okay. Do you wake up at night to catch your breathing?
No.
Any racing and pacing of the heart?
Yeah, doctor, I have this.
For how long?
I don't know, maybe 1 month or two.
Okay. Do you have cough?
Um, Actually, doctor, yeah, I have cough.
Okay. For how long?
Same period of 4 or 3 months.
Okay. This cough is dry or productive? Are you with
Dry,
phlegm? Huh?
dry mainly, but it sometimes gets with mucus, but it's dry
Sometimes.
mainly.
Sometimes. Okay. If the mucus is, how much is the quantity of mucus?
Not that much.
Not that much. Any coughing of the blood?
No,
Any wheezing or musical sounds from the chest?
no easy chest or noisy chest.
Okay. Any history of sore throat?
No, at all.
Okay. Do you have any allergy?
No allergy.
Any past medical history which you want to tell me?
Yes, I have diagnosed before with idiopathic pulmonary fibrosis. And I did for it a transplant for my right lung.
Right lung transplant.
Yes,
When you did it?
the transplant done 5 years ago.
5 years ago.
Yeah,
And after then, you were completely normal, and from the last 4 months, you are having this problem.
exactly.
Do you have any other past medical history you want to share me?
I have a hypertension also.
You have hypertension, and is it controlled or not?
In my opinion, I think it is controlled. No GP told me that it is not.
Okay, are you taking any medicine for the hypertension?
I'm taking many medication. I'm taking
Many medication. Okay.
amlodipine. I'm taking bisoprolol. I'm
Huh?
taking
Again?
amlodipine, bisoprolol, ranitidine, omeprazole, cyclosporin, prednisolone, and cotrimoxazole.
Can I repeat this? Amlodipine, bisoprolol, ranitidine,
Yeah, and omeprazole, cotrimoxazole,
omeprazole,
cyclosporin, and prednisolone.
prednisolone. Okay,
Yeah,
you are compliant. Now, for how long you are taking these medication?
and I'm also taking statin and calci-D. I'm taking them for a long time, doctor.
Statin and
And calci-D.
calcium,
Yeah, calcium with vitamin D.
calcium plus vitamin D.
Mm.
You are taking, you are compliant with these medication.
I'm very compliant, doctor.
Any recent changes and addition of the doses?
No, really.
Okay.
Mm.
And do you have any acidic taste in your mouth?
No,
Okay. Do you have fever?
no,
Any weight changes?
yes. I lost about 5 kg.
Mhm.
Mm.
And what about your appetite?
I lost it in 3 months.
In 3
My,
months.
my
It was
appetite,
intentional?
my
It was
appetite,
or unintentional?
no, not intentional at all.
Okay. And then what about your appetite?
My appetite, I don't know. I cannot comment. For a long time that I'm not like an eating person, but I think I lost my appetite a little bit.
And but do you have night sweats?
No,
Any lumps and bumps?
not really.
Okay, coming back to your transplant, you
Mhm.
told me that you have idiopathic pulmonary fibrosis.
Exactly.
And any doctor told you about the cause of this of fibrosis, or they did not
No,
inform you?
no, just told me that it's idiopathic pulmonary fibrosis, no specific cause.
Okay. Any
Mm.
family history having same
No,
problem or some other problem?
no, doctor.
Do you have any lumps and bumps?
No, doctor.
Any joint problem? Joint pain?
No,
Okay.
no,
Any rash?
no,
Okay. Any problem with your water work?
not really.
Any increase or decrease amount?
No. My water work, I think it's completely fine.
Any change in your bowel habits?
No,
Any increase or any loose motion or hard motion?
no, doctor.
Okay. And do you feel dizzy when you stand up suddenly from your sitting position?
No, doctor.
Any weather preference?
No, doctor.
Okay. Do you have pets at home?
No, doctor.
Okay. Do you smoke?
No, I never smoke.
Never smoke. And do you drink alcohol?
I don't drink alcohol.
And what is your job?
I was um I was a transportation manager.
And now you are not doing anything.
Now I'm driving a taxi.
Okay. And how is it affecting your job?
I think yes, a little bit.
Okay. And then did you travel recently?
No,
Any history of no blood transfusion?
no,
Any tattooing or piercing?
no, doctor.
And needle sharing?
No, doctor.
And history of contact with the sick person?
No.
Okay. May I examine you?
Please.
Okay. I want to. I will. First of all, I will check the general status of the patient. Is there any deformity in the chest?
No
Any?
deformity in the chest or in the back. He looks fine. Maybe like a little bit underweight.
I want to ask you. Does anybody commented that you are looking paler day by day?
No, doctor. Thank you for asking, but no.
No. Okay. And then I will check the hand and clubbing cyanosis.
No clubbing, no cyanosis.
Okay. Pulse
Pulse 89 regular.
and BP. I want to check the BP standing and lying position.
What you say, doctor?
Blood pressure lying and standing position.
No.
Uh, I, I will check the eyes. Any
The
paler jaundice
patient has a tremor, fine tremor.
in the fine tremor. Huh?
Yes. You check the eyes, no pallor, no jaundice.
Okay. And then no pale, no any mouth ulcers,
No, doctor.
any lymphadenopathy.
No.
I want to check the chest. Trachea is central or not.
Trachea central.
I want expansion.
Normal.
Both side normal.
Yeah.
Percussion,
Normal.
auscultation,
Right lung normal. Left lung there is basal find in the inspiratory crepitation.
find and inspiratory crackles. And these crackles, they changes with coughing or not?
No, doctor.
No. And you on left
And
side, crackles on left side or right side you told?
the transplant is on the right side, and there is a right left posterolateral thoracotomy scar in the right, I mean.
Okay, and now the crackles in the left side, left basal side,
Yeah.
and they are not changing.
Yeah.
Okay. Then I want to check the atomy and is hepatosplenomegaly, any organomegaly,
No, nothing on the semi.
any low limb edema.
No.
Uh, uh, okay, Mr. John Smith, as you told me, you are taking multiple drugs like ranitidine, omeprazole, cyclosporin, prednisolone. Can you add more? What I got from your history is that you have shortness of breath from last 4 months, and it is progressing day by day, and you have a cough, and it is a cough, and you also in the past you have 4 years before, 5 years before, you have a right lung transplant,
Right.
and right lung transplant due to idiopathic pulmonary fibrosis. Beside this, you have nothing. Do you
Yeah.
want to add anything?
No, doctor. And I have also a chest pain, by the way, doctor, with this heart racing. I have a non-specific chest pain. It's all over my chest. I don't know what the problem is.
This chest pain is increasing with the deep breathing.
Not related to breathing. It comes suddenly and vanish suddenly.
Okay. And for how long you are having this chest pain?
Maybe 1 month or 2 months.
Okay. So, Mr. John Smith, what is your concern?
I'm really concerned about my transplant lung.
You are really?
Concerned about my transplanted lung. I'm afraid I'm losing it.
Okay, after taking your history and examination, I have some possibilities, and I will make a multidisciplinary teams,
2 minutes
and
left.
I will involve the pulmonary lung doctor, specialist nurse, and then the specialist doctor. Then I want to do some test and scan of your lung, and when I will having these results, I will be discussing with you. Is that okay with you?
All right, doctor. So what could be the reason of my shortness of breath?
I'm just thinking that you are taking many drugs. You are taking polypharmacy, and I will also involve the pharmacy doctor, so that your transplant team also, your drug list should be reviewed. Maybe there is some medicine which is causing this uh, this this problem for your shortness of breath.
All right, doctor. All right.
Do you have any other concern?
No, doctor. So you were gonna like investigate me and you will update me about the reason.
Yes, I will admit you. I will involve the multidisciplinary teams, and I want to review your medicines. Maybe there are some medicine. There are a long list of medicine. There are few medicines they may be causing this problem. Do you have any hypertrophy,
Any what, doctor?
gum
No.
hypertrophy?
No.
Okay, okay. So what we will do? We will review your medicine, and then we will see what is the underlying cause, and then we will inform you. Is that okay with you?
Please, doctor. Thank you.
Time is up. Please move.
So what's your differential for this elderly man with a progressive shortness of breath that comes up for the last 4 or 3 months?
Actually, in the history, I could not find anything positive which is going towards this the shortness of breath. Patient is having dry cough. I could not find any history of asthma or any GERD or any. I'm most likely I'm thinking about that this patient is taking polypharmacy and maybe one of the drug may be responsible for the causing this problem. And
What else could be causing this shortness of breath? Let's say in general, shortness of breath in an elderly man.
there may be malignancy, but I could not find anything in the favor of the malignancy.
What
And
else?
there may be some infections like
Infection.
infections
Like what infection?
like HIV and tuberculosis, but I could not find anything in the favor of the patient has no contact.
What else? Exactly, what
Uh,
else? Patient on immunosuppressant.
yes,
And
patient
and
is
he's taking
patient.
cotrimazole for it.
It may be patient is taking a medicine, so there may be graft rejection, maybe.
It could be. Yes, why not? What else? So graft rejection, infection, what else?
There
Fine.
may be some the patient is taking autoimmune. Uh, me- uh, Patient is taking medicine which is decreasing the defense system of the patient. There may be something like I want to rule out rheumatoid any joint problem, but I could not find anything about in the favor of this. There may be uh, uh, since patient is taking
Excellent.
many
What else?
medicine, there may be pneumocystic carinae pneumonia may be the cause of this.
Exactly. Why not? What else apart from infection and graft rejection? All right.
And
How you are gonna investigate?
uh, 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 beside the basic investigation CBC, ESRC reactive proteins, I will do the LFT liver function test, and I will do the ABGs of the patient, and the patient is extremely shortness of breath, and I will do the chest X-ray, HRCT, and bronchial lavage to see if there may be
Excellent.
to see any pneumocystic carinae pneumonia,
Good.
and finally, I will also go for the pulmonary function test. And then if I cannot, to confirm my diagnosis at the end, I may go for the lung biopsy.
So excellent. So your differential is graft rejection and
Graft
infection and
rejection,
malignancy also because the patient on immunosuppressant. Do you want to add
patient is
any other thing?
as infections, I told you, pneumocystic carinae pneumonia, there may be graft rejection, there may be malignancy, but I could not get anything in the favor of the malignancy. But most probably, I think it may be infections or graft rejection.
Do you want to add anything in the examination?
In the examination, I want to ask the patient oxygen saturation.
Vitals are normal. Anything in the examination you want to add? Like any system you want to examine?
Any system.
Mm.
Yeah, I almost examine all the systems.
Like a cardiovascular exam or something? Like to see JBB and
Yes, yes. I will. I will go. I will go for the any cardiac murmur or JVP. You are right. And I will also go for uh, these immune suppression medicine, especially cyclosporin. I want to do the level of the cyclosporin.
right. Actually, I don't have any other question.
Yeah, almost time was up, but well done, Dr. Azhar. Nice kid, very nice kid, Dr. Rod. Let's see the
Thanks.
comments. Yeah, you can comment now.
Actually, you did for me more than great. Really. You asked from anything or the observation on polypharmacy, and it is a case for differential only. You said yes, it could be, well, why not? It could be a malignancy because the patient on immunosuppressant, that is why you will do like a band CT for him. Also, you need to ask every patient elderly with a weight loss.
Your voice is very low. Please, can you keep the mic in front of you?
Oh, all right. Can you hear me now? Very good.
Yes, 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 yes.
Yes. You said malignancy? Yes, because the patient on immunosuppressant, you know, lymphoma and skin cancer, you should ask about skin tax and something. That is why you will do like a band CT for the lymphoma and issues. Patient lost weight. Also, you need to ask any patient lost weight elderly about, apart from the pallor, you need to do like a digital rectal examination at the end and do abdominal examination, and you did it. And because anemia is one of the differential for any shortness of breath. Also, one of the differential is pulmonary hypertension, written here. So examine for the like loud, palpable P2, and you did the rest for the hepatomegaly, lower lymphedema, and great GBB. And nice that you ask for a joint pain and rash for the connective tissue disease as a cause, for example, for the pulmonary hypertension, apart from the IBF itself or chronic PE. Heart failure would be a differential, and you ruled it out. It could be ischemic heart disease, atypical presentation in elderly patient. You know, could present with a shortness of breath, and patient has atypical chest pain. It could be infection, and you told about it. Very nice. And it could be like a progressing of the IBF in the left lung, or it could be a rejection, as you said. And here it will be bronchiolitis obliterative. Apart from that, I have nothing. You did more than great. Thank you.
But this case was very good. You give me a long list of medicine.
I
And I
I,
was thinking there
I
is some
agree with
medicine.
Doctor. Yeah, but you did
So
it perfect, Doctor Azhar. Really, mashallah, very amazing performance today. You ask every single question and you reach to the case. You ask about contact with sick patient to rule out TB. You ask about the travel, all the causes with the risky behavior to the patient. You did it. Blood transfusion, piercing, tattooing for HIV. Yeah, this is the way how to screen for any immunosuppressed patient on medication to prevent the rejection. Although you can put the rejection still one of the definition, you can say, yeah, worsening of the original disease, which is the fibrosis, but you have to compare the side of the crackles, for example. If you say the crackles on the same side of the original disease, yeah, so it's worse. If there is crackles in the new transplanted liver, or sorry, lungs, you have to think about something happened in the new lungs, the new transplanted one. This is as differential, so the rejection, of course, myeloproliferative, lymphoproliferative, yes, cancer, and the recurrence of the original disease or worsening of the previous or original disease. It's a nice case also by Dr. Roda as a case for differential. I like it. Very nice case to present and to be in the exam and to think more. You have to memorize the all medication she gave to you and try to highlight which one might be related. Once you have a medication with side effect, you have to put it in your list. Like in this case, you have to try it for tacrolimus and tremors. You'll make a circle. You will say cyclosporin with gum hypertrophy. Although you forget it in the examination, but you remember at the last moment, which is very important. You have to ask him, just show me your gum, or give me a smile, or you can ask him, please raise your lips up. Apart from this, yeah, I think also no comment. You can get the full mark with no doubt.
thank you, thank you.
Thank you. Well done,
Dr.
Dr. Az. Yeah.
Dr. Rosa, can you write down in the group all the medications? Because I could not. I tried to
As
write all these, but you were very fast. Please write down in the group all the medicines
by the
and
way,
the speakers also.
this is the way how to see the medication list in the exam. Like they are giving you for a while. Have a look. Thank you. They will take the paper.
He
At
will take the
least,
paper back.
yes, they will take. So what you will do, write the most important related to the complaint. For example, in this patient, you suspect rejection. So you will write the cyclosporin and you will mention it in the differential and you will
In
mention it
my
in the
exam, they
investigation.
left the paper with me till the end.
No,
But it is 15 medication for
15
these patients.
medication. Oh my God.
Yes, and you will not have time
Yeah, you will never
to put in your
memorize.
mind. But according to the history, you will search about what you need to see in the
Yeah, so
medication.
you exactly. So you will circle the medication might be related either by side effect or you have to give him counsel to give him red flag. For example, you have patient with upper GI bleeding and patient on non-steroidal, and you see the medication, you have to give him advice, please stop this medicine. I need from you to stop this medicine. It might be the cause of your case. And if you want to take, you have to take it with or after medical advice. Aspirin for also the kidney. If you have patient with acute kidney injury and patient on non-steroidal, you have also. So try to pick up the medicine which is harmful related to the case. Okay, this is the way how to. Otherwise, he will show you beta blocker, aspirin, amlodipine, thiazide. So according to the case, for example, beta blocker. If you have beta blocker, bisoprolol, for example, and you have patient with bradycardia, so you will circle bisoprolol, patient bradycardia. Inhaler, beta agonist, patient has tremors, complaint of tremor, and you find the patient on salbutamol. I will circle it. It will be one of my differential. This is the way how to correlate and how to pick up the relevant medication to your case. You got it, Dr. Azhar.
Yes, yes, yes.
Yeah,
Please,
even
and
50
Rhoda,
medication. Sorry.
can you write down the differentials in the group also? Not in the chat box. Please write down in the group and
Okay.
medicine because I think this case may come in the exam. This is very
Yes,
uh,
it's common. And the clue, please ask early about any past medical history I should be aware of. This question open up a lot of doors for the case, starting from transplant, original IPF. So at least now you have to screen about two conditions, which is related to the complaint, cough or short of breath or whatsoever. You have to ask this question early, otherwise you'll be roaming from here to there, system review, family history. And when you find past medical transplant, oh my God, I waste a lot of time, which I can save it if I ask this question earlier. Please ask this question whenever you have patient with weird or something different in the complaint. If you find elderly patient, you can ask. For me, by default, I will ask it after constitutional symptoms. So I will ask the complaint analysis. Constitutional symptoms, loss of weight, loss of appetite, night sweats, body temperature, lumps or bumps. What past medical history of note? It will open for you a lot of things. You have to relate it to the case. Okay?
yes.
Apart from this, you did it very, very perfect. I don't have comment. If someone has comment or question, please raise it.
Three things in the history we should ask very early: PDF, past medical history, drug history, family history.
Yeah.
Rest of them we can ask later on. These three things may give us any clue.
By the way, if Dr. Rhoda want to hide, she might tell you, I don't have past medical history, doctor. But if you ask any surgery, she'll tell you, yes, I did transplant. If the surrogate is not cooperative, or it might be also instructed by the examiner.
You are right. You are
Yeah.
right.
So
Surgery should also be
better,
asked. I
yes,
never ask.
past,
I never ask in
past.
my
And
history
some
surgery.
No, no,
things
no.
it will be not logic in there because they need from you to focus on something. Like in my case, I asked about cough, any cough like that. They said no. And when they show the list of medications, there is 3 inhalers and nebulizers in the medication list. So I suspect they will not need you to go to this site when you ask about the cough because it's case of heart failure. Like
You mean it might be related to the medication?
No, just I tell you that if the surrogate denied something, they didn't tell
Okay, yeah,
them
yeah,
about
yeah, yeah, yeah,
to
yeah, yeah.
make it okay. Yes,
They will help you in this. Yes, you are right.
yeah.
They will let take you more in the details of this medication. I agree, but also they might be instructed to try to hide the
But I
the
think no, yeah, yeah, if something like that,
suppose Dr. Aisha. Yes, suppose yes.
yes, it will not hide you because it is complicated case already.
I agree with you. Yes, it's enough the number of medication. No need to be more complicated by
Number of differential in your mind because a lot
another
of things.
yeah,
Yeah,
yes,
yes.
yes, you're right. Yes,
Mm.
but
But in exam, yes, they bringing like case of for differential. They need you to be open and to see a lot of things. Not all the cases you have specific diagnosis, and you will tell the examiner that your diagnosis.
yes, exactly. Try to put the differential and try to put the more related and the most serious after the more related. For example, in this patient, what the most serious here?
I
For
think the
example,
rejection here and
yeah, rejection, because you
yes,
have to call the transplant team. And the most
and this
related,
is condition.
infection,
Yes,
for example,
yes, yes.
or HIV. So this is the way how to put the differential makes sense for the examiner.
And they like this obliterans to mention it. This
Yes,
the one of
yes,
causes of rejection. Yeah. Or
of
symptoms of
course you have.
rejection.
You
Mhm.
have to. You have to. Any patient with transplant, you have
Bronchiolitis oblate. Yeah.
bronchiolitis obliterans also. Very nice differential in this patient. So again, the differential will be infection, rejection, or bronchiolitis obliterans, worsening of the original condition, and cancer, of course, because of immunosuppressant. Okay. I remember something in this scenario. Yeah, try not to mention multidisciplinary to the patient, Dr. Azhar. You are saying we have multidisciplinary team approach. You can say we will refer you to a group of doctors, including your transplant team, the transplant team which you are follow with, including the lung doctor, including the heart doctor, including the pharmacy because of polypharmacy. Yeah, I remember now. What the definition of polypharmacy in basis? How many medication can I say this is polypharmacy? More than
Three.
more than five. No, no, more than five. More than five is polypharmacy. And you can say it whenever you find patient with strange complaint. Patient has dehydration, for example. So, and you have a lot of medication interaction with each other. You don't know exactly what the cause. You can say, yeah, this is polypharmacy. But in this patient, I think the medication it's not related. Immunosuppressant, yes, one, but the polypharmacy is not the one causing the short of breath. Unless you have a drug can cause cough.
Maybe he means that something interact with something like the
So
immunosuppression to
what's
be
the
high
yeah,
level like that.
okay, okay.
Mm.
Or you know if
And
you
there is
if
interaction causing more anemia, more like that
yes,
also
yes,
you
if
can
heart
say.
failure associated, yes. Okay,
Mm.
we can say also if the patient amiodarone, for example, amiodarone, and he
But I
has
think
this,
this will come at late differential because you have already a lot of differential at first.
yes, you're right. And
And
also the
no
loss of
change in
weight.
dose, and he follow up regularly. So
Yes, no
mm,
added medication recently, no,
yes,
and there is weight loss. I agree. Okay, any question else, Dr. Aisha? Any comment?
was very very nice cases, and
Yes, nice
I'm
cases as
embracing
usual.
about these days of cases. This is thank you really.
Yes, you help us a lot, Dr. Roda and Dr. Azhar. Good performance in both ways, either candidate or surrogate. Although Dr. Roda seems too busy, may Allah bless her and her baby, but still she can give us a lot of nice cases.
Very nice.
MDT, yeah, yes, and performance as well. Any question else? D-dimer echo, yes. You have to think about, I didn't read the comment. Yes, you have to think about PE, of course, because of immuno. Cancer itself is procoagulant state. if you can say PE, it will be accepted. Short of breath, chest pain, pulmonary hypertension, yes, of course,
History is very,
cytomegalovirus,
but history is very long, 4 months.
chronic TB, chronic, and will lead to pulmonary hypertension. Graft rejection, BCB pneumonia, of course. Specific question of BCB pneumonia you have to know, or you have to ask about, like how many steps, and you have dry cough. This question for,
Dry cough
and within it's there is a test for the BCB pneumonia. You ask him to walk. I think it's 10 steps.
desaturation after walking few steps.
Yeah, few steps he will be having desaturation. Yes.
Desaturated. And we
And
will
there
do
is
the investigation ball to see any silvers, I think silver staining.
perfect. Yeah, silver stain in the ball. Okay, what indication of steroid with BCB?
What think if
The
the
indication of steroid.
yeah, partial pressure of oxygen is less than
Exactly.
7.3.
Yes. Less than less than 8, I guess.
Less than 8.
PO2. Yeah, the
Less
7.3 you mentioned, it's in the core pulmonale, right side heart failure, and the indication of oxygen.
oxygen. And
Yeah,
for
yeah, so
period less than
this,
8, less than 8
yeah, less than 8 PO2.
PO2.
Why not IDF as a differential? IPF, you mean, interstitial pulmonary fibrosis. Yeah, we mentioned it.
Okay, yeah. But why
I,
not this first, then the graft rejection, then heart failure, like that?
it might be as a differential.
Because like the
But
patient
because
has
she
a
has
history of
one lung healthy, if she has one lung healthy, I think no deterioration like that.
Unless the healthy lung will the one affected, so the patient will again complain of short of breath because the left one or the previous one or the old one already diseased. So the complaint here will come after affected the new lung, not the old one.
but like that might be like before she had like normal lung, right lung, and after that maybe like after transplant she has like developed the shortness of breath. It
The
can happen.
transplant after 5 years.
Okay.
You mean if we put IPF here is not making sense, right?
Yeah.
Yeah, you're right. Yeah, if after 5 years and he already live with the old lung and the new one, suppose yes. So the pathology will be in the new lung. Yes, you're right. Yes.
But the Dr. Ruda, she gave me history of transplantation in the right lung. Now fibrosis in the left lung.
Yeah. Okay. The question now, does the fibrosis recur back to the new lung, not for the old lung already fibrotic? The new lung,
It will
Which has been transplanted.
sorry, it will not affect or it will affect.
affect, right?
It will affect. It will affect.
Yeah.
Yeah, so because of the pathology is unknown and you don't know what if it's already affected by the fibrosis or not. So we can say recurrence. Recurrence to the new lung, not the old one. The old one already fibrotic. Okay?
Yeah.
Okay, good discussion. Thank you, Dr. Sam. Thank you for active participation and interaction in this comments. I think all satisfied. Any question? Any question else? Any comment?
Thank you
Oh,
for the cases.
yeah, very nice case. Okay, if no questions, we can end the session. See you tomorrow with Communication Day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.